Well, welcome everyone. This is the Designing Better Experiences for Patients and Care Teams track. I'd like to welcome everyone today and thank you for joining us. My name is Emily Czar and I'm part of the Experience Strategy team. We use qualitative research to look at how patients' behaviors and barriers contribute to experiences and try to find opportunities to elevate and alleviate complex experiences through service innovation, integration, and human-centered design. Each of these steps is essential to any strategic approach to experience design and together form the skeleton of a human-centered design process. We see more and more organizations and industries adapting human-centered design processes to inform their strategic visions as much as elicit and answer key questions about their customers and patients that lead to new innovations, value propositions, and ultimately better patient experiences. This track today will be talking mostly about process and emphasizing different parts of the human-centered design process. Our speakers will each focus on one element of this process. And first we'll be hearing from Shannon Ford, who will be talking to us about remote observation and how to adapt a research process intended for field visits during this COVID-19 crisis. You know, during the pandemic, a lot of the qualitative research that we normally do, we've had to adopt and adapt new processes for. So we'll be looking to Shannon to talk to us a little bit about that. Then we'll be hearing from Rachel Carmen Caesar and Lisa Yoshiko from Kaiser Permanente, who are going to walk us through some of the tips for cutting through data analysis in healthcare, which we know can be layered with complexities and incredibly rich, but also really complicated. And then lastly, we'll be hearing from Jody Butts and Antonia Lorza from Cerner, who are going to walk us through their story and approach to taking action on complex data and making those insights actionable. And so through these three sessions, you'll kind of hear the different ways that they approach this, and also through the three, you'll see kind of a complete human-centered design journey. For our tracks today, we'll be including time for Q&A at the close of each talk and invite participants to submit questions via chat that I will collect and feed back to our participants. So without further ado, please join me in welcoming our first speaker, Shannon Ford. She's going to talk to us about field visits during the COVID-19 crisis. Welcome, Shannon.
Thank you, Emily. Can you hear me okay?
You're great. Thank you.
Awesome. Okay, I'm going to share my slides. Just a moment. All right, and I just want to double check and make sure you're seeing the slide and not the speaker view of this. Awesome.
You're great, and we can hear you. Thanks, Shannon.
All right. Thank you so much, everybody. Good morning. I'm super excited to be here. I really enjoyed the conference yesterday, and just very pleased to be able to be invited to speak with you guys today. As Emily mentioned, I'm going to talk about doing field visits during COVID-19. My name is Shannon Ford. I'm a design researcher and a UX designer, and I've been practicing in this field since before the first big .com crash. So that's more than 20 years ago. I've been a consultant for a really wide range of clients, large companies, small companies, lots of different kinds of products, but I've been working in the nonprofit and social services space for the last 3.5 years. And just on a personal note, I don't have a nice professional image, which I feel I should have, but I picked this picture out because it's from the research. And it was about 8 months ago, which seems like yesterday, but at the same time, I feel about 500 years older than this picture. And yet I'm still in the same room. So that kind of encapsulates my last year of COVID experience of weird time frames in my little room here. I work at Alluma, and we are a social technology nonprofit whose mission is to eliminate barriers to getting people connected to help of all different sorts. We have two main technology focuses. One is a community-facing resource and referral platform called 1 Degree, and the other is an application eligibility and enrollment platform for benefits program called 1X Connection. So this is the outline of the talk. We'll talk for about 20 minutes. I'll give you a little background on the project, talk about the original research plan, how we shifted that to a virtual fieldwork setup, basically what happened, what the successes and challenges were, and then wrap up the lessons learned at the end. So project context. In this project, we were working with an agency to implement an application eligibility and enrollment system for a new healthcare coverage program. And that program was designed to provide primary care coverage to adults living in any of these 35 California counties. They're mostly the rural counties. And these are for adults who basically make too much to qualify for Medicaid, which is at 138% of the federal poverty level, up to about 300% of the FPL. So basically in that income between 138 and 300%, you're still not making enough money to afford the exchange healthcare coverage, even with subsidies. And so this is a program that's basically a stopgap in between Medicaid and those other opportunities. And our users are assisters who work in clinics, and their whole job is to help people apply for and enroll in this program and others like it. And so they're usually dedicated to applications, renewals, basically trying to help people find the best programs that they can so that they can get their care in the clinic covered financially. And so they're helping people with programs from major public benefits programs like Medicaid and SNAP, to county level programs like the one we were working with, to hospital charity programs, or even the clinic's own programs. And these guys are incredibly dedicated. They will bend over backwards and suffer through all sorts of crazy systems to make sure that people get the care that they need. Our patients themselves are not using the system, but I consider them to be a secondary user because they are with the assister as they're going through the process. And so they're experiencing that system in a secondhand way. So our original idea was to do in-person field visits in several clinics, and we wanted to do a couple different things. First, we wanted to shadow 2 assisters for a half day each. And then we also wanted to supplement that with semi-structured interviews with additional assisters, their supervisors, the program managers who make the decisions about what coverage programs to support, and even front desk staff. So basically getting a full picture of anybody who is touching that patient and helping get them connected to these programs. And just in case there's anybody in the audience who isn't familiar with the idea of shadowing or semi-structured interviews, shadowing is when a researcher follows a participant over the course of an activity or over the course of a time period of interest. So for example, an activity might be shopping for an apartment, which is what's happening in the picture on the right-hand side, or a time period could be something like following a family through their morning routine or through an evening routine. Shadowing is primarily an observational activity, but the researcher may occasionally interrupt to ask clarifying questions. And almost always there's a follow-up interview so that you can have a more detailed conversation about what you've observed. And so the goal is really to see what do people do, including their interactions with their spaces, their workplaces, other people they might collaborate with, the artifacts that they use and tools to do their job, while also having the benefit about questioning what you've seen, which you can't do in a pure observational setting. And then semi-structured interviews are when the researcher approaches the interview with some predefined topics, but the discussion's left open-ended enough to allow for the discovery of new topics. And so researchers treat the participant as the expert on the topics of interest. And so it allows the participant to bring up things that the researcher wouldn't necessarily even know to ask questions about. The interviews are inductive in nature, and by that I mean it's sort of a bottom-up reasoning process where we're not going in with a hypothesis to prove, but we're trying to create a hypothesis from what we're learning in the interviews. And so both this and shadowing are very exploratory in nature. These semi-structured interviews are important to take place in context as well, usually at home or a place of work. And the reason why context is important in both of these situations is that if you're talking to someone, there's so much that you do and use that have become habit, and you don't even think about them anymore. So as a researcher, I can see things in your environment or see you doing things. I can ask you about them that you might never think to tell me in the first place if we were just having an interview out of context. So that was our plan. And by the time sort of the ink dried and everybody got board approval and everything happened, we ended up in COVID. So we were wanting to go into the field right around where you see the 7-day average figure last summer towards the end of July. And so that just basically took in-person clinic visits out of the picture. And then it turned out that most of the assisters weren't actually in the clinics themselves either. They were working from home as well. We did have some clinics who had assisters in the office, but they were having their appointments over the phone. So the patients weren't coming into the clinics. So there's really no opportunity to go to the clinic, and there was nothing really happening most of the time there anyway. So our first thought was like, okay, we're going to have to drop this part of our research. But then we started thinking, okay, how about if we do this virtually? And remote research is not new at all. It's something we're comfortable doing for usability testing. We do it for small group work sometimes, SME interviews, that kind of thing. But field visits, the whole point is to be there and to see the assisters and the clients interacting, see the movement of people and paper through the office, to see what cheat sheets they're using, all of that stuff, where they're used, where they're kept. And so we were still a little bit uneasy with the idea and how we could accomplish that. We had done some remote shadowing of people applying for SNAP or Medicaid through self-service portals, so that we knew that as long as what was happening on the screen was of importance, we'd still get some value out of doing observational research remotely. In this case with the self-service, it was still not quite the same as the situation we were going into, because these were individuals, they weren't interacting with another person. There was, fewer artifacts to look at, but this was enough to give us the hope that we could get something valuable. So what did we actually do? Our setup was like pretty basic. We set these up as video conferences with screen sharing, so nothing earth-shattering there. For shadowing, our sisters were working with people over the phone, as I mentioned before. So we simply had them put their clients on speaker. Clients with appointments were told beforehand that there would be people observing and shadowing. And then we reiterated with them once we got them on the phone that we were there and asked their permission for us to be there. We planned on using Validately as our research platform. It's a purpose-built platform that has some features we really like. You can have a few more people join the interview without overcrowding the participant. And then they have a really great tech check feature that makes it really easy for people to onboard onto the system. So we were good to go there. And then we went through sort of our typical preparation. We sent a 3-page document to our clinics to talk about who we wanted to talk to, what they should expect, before, during, and after. We then got on a conference call with the person who was coordinating our visit, talked about the technology that would be involved, talked about exactly which staff made sense to talk to based on their work process. And then we set up those sessions and created our meetings, our invites, had instructions on how to use Validately, and giving everybody phone numbers to make sure if something happened, we could get a hold of them. So that all was pretty standard practice as well. So ta-da, what happened? We went into the field. It worked for the most part. And so there were some successes and challenges I want to talk about. The challenges I'll do first. There were in nature 2 kinds of challenges. One was around technology. no surprise, and one was around context, no surprise. So first challenge was with Validately, our lovely platform that we like so much. So we had asked clinics for permission to record the shadowing sessions. We were not able to get permission to do that. So as we were testing out the Validately platform in our dry run, which is highly recommended to do, and most people do that as a standard practice, we found out that you can't actually screen share without recording. So Validately went out the door for shadowing. We'd also planned on using Validately for the interviews. So despite having talked about technology in our site meetings, those initial meetings, we ran into some in-the-moment issues with the clinic's technology where we couldn't connect to computer audio. And so our participants needed to call in on a phone line. And Validately at that time didn't have a really easy way to do this. So we did a really quick punt to using plain old WebEx as our video conferencing platform. We weren't, as an organization, using Zoom at that time. If we had, we would have had a little bit of better success, but that wasn't really an option for us at that moment. So then technology, WebEx had its own issues. So we ended up with this mix of, people with perfectly fine setup. So we had audio, computer audio, we had computer video, we could see everybody, it was great. Then we had a couple other situations. We had some people whose computer audio was not working, so they had to call in, and we would get basically a picture like we see on the left-hand side with WebEx. So we have our participant in this case is in the middle. I've got my colleague on the left-hand side, that's me on the right. And when she was speaking, we got a nice picture of this big C for call-in user. And this is where Zoom would have been a much better platform, because Zoom would have actually showed us her picture and not this big blank screen. And then we also had some people who had neither video nor audio. And so in those situations, we just sort of rolled with it and did the best we could with the tools that we had. We were able to do a few things like have people get loaner computers to have the video and audio be working, but it wasn't possible in all situations. So the second challenge was around context. And in most cases, the webcam allowed us to see the room context. So when everything was working well, and people could hold artifacts up to the camera to show us, like the one on the left-hand side. And I chose a blurry one on purpose just for sharing purposes here, but we could actually see things pretty well in those cases. And then for people who were using the phone on the right-hand side, even though that picture is really small, we could still see the context of her office. This participant was in the office. And when we were talking to her, we could see her keep looking up at the wall. And so we would able to say like, hey, what are you looking at? And she would say like, oh, my brain is on the wall. All of my projects are up there. And so she was using that room context to, in her answering. And we were able to see that. We were able to query it in the same way that we might have if we were in person. We also had the opportunity to have people share screens in the interview sessions. In the shadowing sessions, we of course were doing that automatically. And then we had a couple instances where we asked people to actually send us pictures of some artifacts that we were interested in afterwards. So the successes were a twofold. One was that we got a really interesting view of clinic ops during COVID-19 that we really wouldn't have gotten if we hadn't decided to go ahead and do the research this way. And then we also got some key insights that drove functionality in our system. And I'm going to share a couple of those insights, but I have to do a quick explainer first. And that is the clinic's assisters are basically sitting with the patients. They're finishing the application, putting all the data in. They're collecting all their validation documents that show their income, their identity, those kinds of things. And they're sending that bundle into our client system. And on the client side, we have an eligibility worker, and their job is to look over the application, make sure all of the documents are in order, and then make that final decision about whether to approve or deny the application for the benefit. And the eligibility worker has about 30 days to make that decision and make that turnaround. So one of the things that was super clear from the research is that waiting for those results of whether they were approved or denied is a major source of frustration and inefficiency for assisters in the other systems that they're using. And so we came back with a really clear imperative to make that determination process transparent, so that assisters could see what applications were still being worked on by the eligibility worker, how long they still had in that 30-day time window before their time was up. You know, basically, when should I start calling the eligibility worker and ask her what's happening? And then also, once that had gone through, whether their patient had been approved or denied. And I don't think we would have had quite the same drive and quite the same insight of how to do that if we hadn't done this research. The next thing that was interesting is that speed to decision was more important than speed to apply. So my organization was very focused on how do we make this application go as quickly as possible, ask for the least amount of information possible, make it super easy to attach documents. And really, like, we weren't paying as much attention to how do we make that eligibility workers turnaround time go faster, because that's what's really going to make the impact in the end. And then the last one I'll point out here is that, you know, COVID-19 was making collecting those verification documents even more painful than it is normally. And it is normally a very painful process. And this one assister explained how, you know, people were sending her text messages of their documents, images of their documents, but she had a flip phone for work. She didn't want to give them her private phone. So then she forwarded it to her personal phone, which then she could forward to email, which then she could download on the desktop to get it into the system. And so COVID just made everything more complicated because everybody was cobbling together the system to make it work. So I'm going to sum up just with a couple of the takeaways that you will recognize from what I've already talked about. So we usually give time and attention to technology, but in these times, give even more time and attention to that technology. The planning, the dry runs goes a long way. But I would suggest planning for more session time just for technology wrangling, or perhaps even having a pre-check meeting where you might get on for 10 or 15 minutes, make sure the setup works, and then come back and do the interview at a later time. And then to always have, you know, 1 or 2 backup plans ready to go if things don't work in the moment. And then the next is find other ways to get contextual data. So during our planning, we did consider asking the assisters to do a photo tour of their workspace ahead of the sessions so that we could sort of see that whole work context. And we decided to hold off for a couple of different reasons, but I think this would have still been a fruitful way for us to get more data about the environment that we were working in. You could also use some more pointed questions. You could just simply ask, like, tell me about your setup right now. What's the thing on your desk that you use constantly? Show it to us, that sort of thing. And then you could also use a more purpose-built platform like DScout to document environment and tool usage like over the course of a week even. And DScout just makes it easier for you to sort of push those tasks out. It's very mobile based. It helps you organize the visual data that you get back. So those are nice to have as well. And then finally, I'll just say you can get value out of doing this work virtually. I still would rather be in person, but I'm really glad that we did this. You just have to be flexible and be okay with less than perfect data. So with that, thank you very much for listening, and I'll take questions, or if you have stories of your own, your tips that you want to share, that would be great too.
Great, Shannon. It looks like we have a question in the chat here, a couple questions coming through right here at the end. How would you approach situations where you need to observe tasks involving EHR usage, where real patient information may be visible, but you can't get permission from the patient themselves?
I don't want to pretend to be an expert in PHI. In our shadowing, the assisters were using their EHR constantly through the whole thing. They would be switching back and forth between the EHR and the application systems that they were using. And I think that that's why the recording piece of it was not allowed, and we would have needed to go through, jump through a lot of hoops to make that happen. But they believe that they're working under the assumption that the HIPAA rules are being followed by the assisters. We're a covered entity, so we have to abide by those principles as well, and then that's covered. But I know that there are other people maybe in the audience also who would have a more complete answer to that.
Mm-hmm. And kind of a two-part question here. How many users had to comment on a pain point? This is kind of a philosophical question, I guess. How many users had to comment on a particular pain point before your team decided it was worth addressing? Or I think a more general way of reframing this is, was every pain point addressed if it was only mentioned once? How did you guys kind of approach thinking about that?
Yeah, so this is my personal philosophy after like X number of years. We're always looking for patterns, of course. This is qualitative data, so I can't say, if we get 95% of the people saying it, we're going to fix it. We are looking for patterns. Those patterns are evaluated for the severity of it, and that's how we're making a decision. But I definitely, if I hear something compelling and powerful from one person and I can extrapolate that makes sense to me, and I think we need to do that, I'll fight for that one person's comment as well. So it's important. Patterns are helpful. It helps people have confidence that there is an issue there, but I won't discount a single person. And I don't know anybody who gets every pain point into their system. If you do, like, tell me how you do that.
Right, certainly. Yeah, so using patterns to kind of narrow the focus and kind of find where to pay attention, but also maybe not eliminating those things that might be kind of screaming headlines.
Exactly, yeah.
Love it, I love that. Great, let me see if there's any other questions in here. I have a few questions for you. Any kind of major takeaways on kind of how you would prepare patients in terms of managing expectations and getting them ready for kind of these types of remote observations? Now, on the other end of it, like, if they'd set up their cameras in a different place, or if there was a better way to get more of a view of what was going on, in their surroundings. Any kind of things that you would kind of include in that setup, that introduction that you might send out to patients in the future?
Yeah, so we, in this research, our users are primarily assisters. And so we were observing patients over the phone via the assister. So it wasn't so much a patient interaction as an assister interaction. These guys were just, they're swamped. They were overloaded. They were dealing with a lot of stuff themselves. And so we didn't feel like we wanted to push it too far in terms of like demanding different sort of video setups or making them like really kind of push out their comfort zone for how to set it up for us to have a more successful thing. So I have thought about that a lot. How much technology can you expect people to wrangle in order to make things better for yourself? And I think you have to just think about what's the technical expertise for people. How much do you want to fluster them and get them confused before you want to have this conversation with them?
Sure, sure. Because normally, right, like the idea of observations is you're kind of a fly on the wall
Yeah.
in their space, in their, in their normal routine, right? So there's a balance, right? How much is disrupted there, and
Yeah.
okay, guy, I love that.
I
Yeah.
definitely think like after so long, I was like, what? Why did I not make sure everybody's like webcam like really worked? There were some things that happened where I was like, wow, what what is my problem there? But those are very simple things, just to not make assumptions that because somebody's working in a clinical setting that they have a computer or they have rules against, they just block their audio and video because of the clinic setting.
Mm-hmm, mm-hmm.
And just the age old, don't make assumptions about anything, check everything to make sure that at least those basics audio and video pieces will work. And like I said, you have some other options for asking people. You can play out, like maybe they would feel comfortable taking a picture and sending me an email of that picture, and that will suffice for what I need.
Mm-hmm. So kind of looking at alternate formats that can achieve what you're trying to do.
Yeah, and try for our populations, like lower tech is better too. So I'm sure there's some fancy things that we could have done with some other platforms that maybe would have been too much for this situation.
Yeah, nope, totally fair. Got to know kind of what your audience and how they're going to react to the technology aspect of this kind of new format. Another question here in the chat, how important was the trust between assisters to get patients to agree to remote observation? So yeah, how did you kind of build that relationship and get through that bridge?
The assisters have that relationship. The clinic has that relationship with people. So when the patients are going to those assisters for help, there's already a trust factor built into there. So that part really wasn't difficult. It wasn't difficult for them to get permission from people. But I also, like, unfortunately, in this situation, and people are trying to get public benefits help, they sort of feel a little trapped, right? They basically are forced to do whatever they're forced to do because they need the help, they want the help, and so they wouldn't refuse. Right. So there's a little bit of a sticking point there, but I do think they do have a lot of trust in the clinic settings, where we've done work with assisters in other clinic settings, and they've also talked about that there's a natural trust that people have in that setting, and that just translated over to us as well.
So kind of a trust and also the relational need there.
Yeah,
that's super relevant. But I think
yeah.
it's worth noting, because other people, in recruiting and kind of thinking about bringing people in for these types of participation, you are having to think about that kind of two layers of participation. And so that's a little bit tricky there. So super nuanced. Let's see, we have another question here. Assisters were working from home. How did you think about that shift in their context as a factor in their work? Would you change anything in your process if they were in an office setting, in a clinic setting?
A few people were in the office, and most were working from home. I mean, I think it was definitely clear that the shift in context affected their work. So, for example, and this was important for us to know as well, usually assisters are working in a specific clinic, but these clinic organizations can have multiple locations. So what was happening when people working from home and, some people being out, taking care of family or what have you, they were actually taking calls for patients from other clinics. So that was definitely a shift in, usually I only help the people who come to my place, but now I'm helping people who are like, in this even other county, get help. And so the flexibility of data visibility and being able to pick up an application that might be in progress but not finished amongst different assisters was definitely affected by how they chose to work around work around their sort of business as usual. And then the whole documentation thing, we could have a whole session on that probably. It's really hard for people to produce those documents in the first place, but there's nowhere to drop them off. There's nowhere to scan them. There's all these sharing mechanisms that weren't, all perfectly in line. So there's a lot of Band-Aids happening there as well.
I'm sure a lot of.
And speakerphone, I don't know that there would be any other way. Their offices have a limited amount of privacy, so being on speaker wouldn't have been an issue in the office. It wasn't an issue in the office.
Very nice. Well, thank you, Shannon.
Thank you, everyone.
I encourage you to stick around for the next two chats, and if people have more questions for Shannon, I encourage you to reach out to her through networking and through this session.